We will be discussing remplissage using percutaneous needle navigation with knotless suture anchors to form a suture staple configuration. The authors do not have any disclosures. A standard posterior portal is established, followed by the creation of an anterior portal. Placement of the anterior portal, high and lateral, aids with visualization of the Hill-Sachs lesion. Movement of the operative extremity to pull downward traction with the arm in 20 degrees of flexion and 40 degrees of external rotation will also aid in the visualization of the posterior humerus and Hill-Sachs lesion. A Remplissage is used to prepare the bone cartilage interface at the Hill-Sachs lesion and prepare a landing zone for future anchor placement. Via the posterior portal, a knotless suture anchor should then be placed in the inferior aspect of the Hill-Sachs lesion. Ultimately, there will be an anchor in the inferior aspect of the Hill-Sachs lesion and the superior aspect of the lesion. The authors of this paper prefer to start with the inferior anchor, as this aids with visualization throughout the procedure. A percutaneous spinal needle is placed at the location of a future posterior lateral portal, and the tip of the needle can be used to confirm the location for penetration through the infraspinatus. Once the surgeon is satisfied with the trajectory and the placement of the percutaneous needle, a posterior lateral portal can be developed into the subacromial space. The surgeon can then use a yellow cannula to sweep the bursal tissue off of the infraspinatus. A percutaneous needle is placed through the cannula, and under direct visualization, the needle is used to pierce through the infraspinatus at the precise location the surgeon deems appropriate for adequate tissue capture for remplissage. This technique is advantageous in that the surgeon is able to make adjustments to where the infraspinatus tissue will be captured prior to irreversibly committing to placement of an anchor through the tendon. A wire loop is then passed through the percutaneous needle that has pierced the infraspinatus tendon and pulled using a grasper through the posterior portal. The shuttle and repair sutures from the knotless anchor are then placed into the loop of the wire loop and can be shuttled back through the glenohumeral joint and through the infraspinatus tendon and out of the posterior lateral portal. As can be seen in the image on the right, the repair suture and the shuttle suture for the knotless suture anchor have been shuttled through the posterior capsule and infraspinatus tendon and out of the posterior lateral portal. This process is then repeated with a knotless suture anchor placed within the superior aspect of the Hill-Sachs lesion. As seen in this image on the left, the repair suture and the shuttle suture from the suture anchor in the inferior and superior aspects of the Hill-Sachs lesion have been shuttled through the infraspinatus tendon and the posterior capsule out of the posterior lateral portal. The repair suture from the inferior anchor is then placed within the loop of the shuttle suture of the superior anchor. The repair suture from the superior anchor is then placed within the loop of the shuttle suture of the inferior anchor. The repair sutures are then shuttled and tensioned via the knotless mechanism to form a suture staple. Via the camera in the anterior portal, the infraspinatus tendon and posterior capsule can be directly visualized. As the surgeon tensions each limb of the suture staple construct, the infraspinatus and posterior capsule can be seen reduced down into the Hill-Sachs lesion as the suture staple compresses the infraspinatus tendon. The camera can then be moved from the anterior portal to the posterior lateral portal to visualize the suture staple compressing the tendon. At this stage, the suture should be cut and final arthroscopic images should be taken.